Welcome back to this series on the PPRP checklist on pre-hospital pediatric readiness. We are going to talk about everybody's favorite subject, which is policies, procedures, and protocols, as if we did not have enough P words in this conversation. So this is a big section. It also includes medical oversight, so an M word, and it spans multiple parts of the EMS system. And I think thinking about stuff at the agency versus a regional versus a state level, I think some of these things are going to be met by like state or regional standards. So that might be a good starting point to talk about. So the first one is on dispatch, which is pre-arrival instructions identified in EMS dispatch protocols include pediatric considerations when relevant. So for respiratory distress, cardiac arrest, choking, seizure, consciousness. So can you give me an example of what it would mean to have a pediatric consideration in my dispatch protocol?
I think it would be specific to the instructions you're giving. So we know if they're giving instructions for like rescue breathing, choking management, or chest compressions, there's difference in rates and technique between infant and children and adult. So I'd say the pediatric specific would address the differences from what we would tell them to do to an adult patient.
No, I think Chief Pinchalk said it all. For instance, if you use choking as the example for an adult, you could do it with the Heimlich maneuver or use a chair. If you have an infant under the age of 12 months, you would be doing 5 back blows and then, turn the infant over and then 5 chest compressions on the front. So it's very different than an adult. You're not going to flip an adult back and forth when they're choking.
At least not well.
Well, if you're hopefully not. So yes.
So that's it. So even if you are not in charge with your dispatch, I think we are a system of care. I think the place in that checklist is reaching out to your dispatch center or the medical director of the dispatch center and analyzing sort of some of those conditions or where you want a pediatric specific guidance. So the next section is that policies, procedures, and protocols include pediatric considerations such as, but not limited to, and there's a bunch of these, like policy on pediatric refusals and pediatric assessment and consent and treatment of minors, recognition and reporting of child maltreatment, trauma triage, children with special healthcare needs. It makes sense to me that we obviously, have a policy on consent and treatment of minors or reporting of suspected child maltreatment, although usually the child maltreatment is a state mandatory reporting law, which takes care of that. But can you give some example of policies, procedures, or protocol that address, for example, a pediatric specific consideration for a refusal or an assessment?
So it's actually nice and refreshing that Chief Pinchalk and I worked together just a few weeks ago doing our pediatric education for all of our EMS paramedics at Pittsburgh. I want to say they did an excellent job talking about the recognition and reporting of child maltreatment. I know that wasn't your specific question, but what I really liked about what Pittsburgh did was not to just say, you need to do this, but actually go through the steps of how do you do this as an EMS clinician in the field? What numbers do I need to call? Who do I need to talk to? What is my responsibility? And I think to the point that we've been making with our previous episodes, it's not enough to say, hey, yeah, we have a system in place. You have to give the people the how-to. Policy on pediatric refusals. There's a couple of examples that I'll give. One is, again, this is why pediatric specific pediatric emergency care knowledge is very important. Children under the age of 4 weeks, from like basically birth to 4 weeks, are considered newborns to 28 days. If that child has a fever, there are higher percentages for systemic bacteremia, meningitis, things like urosepsis. Many folks, EMS clinicians may not be aware of that. That child needs to be brought to the hospital if they have a fever, which is defined as 100.4 degrees Fahrenheit or above 38 degrees Celsius. That child may actually have meningitis or require a lumbar puncture. And so because, if that is not known, if that specific pediatric knowledge is not known, and the child is well appearing and has fever, it may seem okay to say, oh, we don't need to take this child to the hospital. This newborn, I'll say, this newborn is well appearing. But when you looked at evidence-based care from a hospital standpoint, that child needs to be seen by somebody. Another example is seizures. Dr. Manish Shah has been an expert in this field. A lot of the studies that he has done that shows that there's a significant percentage of pediatric patients that have seizures within the small percentage of pediatric patients that we see in EMS. So we see anywhere from like 5 to 10 or 5 to 13% of pediatric calls in EMS, and about 10% of those calls are pediatric seizure calls. And many of our policies and procedures is that if you suspect seizure, bring that child to the hospital, because there could be myriad of reasons as to why that child is seizing. And even if that child is no longer actively seizing at home, probably should be brought to the hospital to be evaluated, to look at different causes. So those are some nuances. If you are not keen or your agency has not been given the pediatric specific education or knows of the pediatric specific evidence-based medicine around these things, that could be missed.
Yeah, so like our region has a policy that like every refusal for 6 months or under actually calls in to discuss their refusal. And then anything that's a brewy has a phone call. And I think because I think of how much education do we receive and all the ways that kids are put together wrong, and how those things can present. It can be really subtle presentations of a significant underlying problem. And so I think that requires, and a lot of time those kids are very well appearing when you see them, but that's a herald of something really bad. So I think thinking about what policies do we have specifically about refusals, how are we empowering people really? Because I think it's an empowerment to say, like, in these cases, I really need to engage somebody who has more expertise in these cases. And, even now, like I'm a emergency medicine, I saw a bunch of kids in my training. I work at a community hospital. I don't have pediatricians. And sometimes before I send a kid home, I call all my peds colleagues at the children's hospital we're associated and say like, hey, I just want to run this bronchiolitis case by you, because I don't discharge these kids every single day, and tell you what I'm seeing and have a conversation. Do you think that this is a safe disposition or not? And it's because, we don't see potentially sick kids, every single day, or the story, but there's people who have expertise and we should feel empowered to engage those. And so this sort of goes into the next component, which is direct medical oversight integrates pediatric specific knowledge. Do you want to translate what that means, Sylvia?
So it's interesting. It's interesting that you say this. In recently teaching our PALS PEP classes at Pittsburgh, we are fortunate to have two of us. Dr. Angelica Sircone is one of the EMS medical directors here, and is a pediatric medical director for Pittsburgh EMS. Is pediatric emergency medicine trained, EMS trained, right? Those are very much rarities. I am that same, I have that same educational background. And so what we heard from the EMS clinicians is, to your point, Dr. Dorsett, that they want to hear from pediatric experts as to what to do, because sometimes those in training that haven't focused on pediatric care may miss some of the details or the nuances, like some of the things that I talked about. The newborn is the example I love to give, because newborns can be very deceiving and look very well, but be very sick. And so unless you have that pediatric specific knowledge base to tell your EMS clinicians that, yeah, I know the child looks well, but I'm concerned because of X, Y, and Z, because of my pediatric expertise, it may be hard to do the right thing for the child. And so I think what we talked about before kind of spills over into this, that making sure that your medical oversight team, whether that be medical command or public safety or however it runs, you have resources to pediatric experts. Do you need a triple boarded pediatric emergency medicine person? Not at all. That's not to say that. It's just to say, to Dr. Dorsett's point, that you have some pediatric experts that you can, or liaisons that you can easily reach out to make sure that our EMS clinicians are getting the best medical oversight. In some cases, that can be like a three-way call. Maybe you have a medical command center with your with your medical director, who is emergency medicine trained, and then you loop in a pediatric expert to be able to talk to the EMS clinician directly when we're talking about direct medical oversight. In some of our fancy cases where we have pediatric medical directors, you have pediatric medical directors and chase callers. But I realize that the majority of our agencies, that is not the case. But the point there is to use your pediatric liaison in your direct medical oversight. And when you are, indirect medical oversight would be when you're putting your procedures and policies together, that kind of spills into the next check box. Make sure you have a pediatric expert on that committee or within the room to go over the protocols with you, specifically comb through the pediatric specific protocols. And I think in Pittsburgh, we do a great job of that. In the Commonwealth of Pennsylvania, as you know, Chief Pinchalk and myself are on the EMSC committee. And so we have folks both who are EMS clinicians and physicians who have pediatric expertise that can speak to both direct and indirect medical oversight.
It has a checkbox about policy, procedures, protocols, and you can have all that, but there's still just a tremendous amount of gray areas in there, unusual situations, or just, I have no idea what the heck's going on. So as Dr. O said, we really push, hey, take the pressure off yourself, kick it up the chain, get the doctor on the phone, have the resident come to the scene, get a supervisor involved, and get that joint decision-making with the experts. And that takes that burden off of you. You're not making a best guess. We're making good clinical decisions with an expert.
Yep. So in places other than Pittsburgh, where you can call a physician to the scene or you have a pediatric medical directors, right? I think that there's different ways that you can meet this. So, in our region, we have it. So they call for pediatric calls. They call one of two hospitals that have access, that have pediatricians working in the ER, and the comm nurse who answers those routes those calls to like the pediatric emergency department. It's thinking like, what resources do I have in my community? I think in places that are more potentially rural or have like less of those specialized resources, right? Like the communities do have pediatricians who are there, and sometimes if they're not at the table yet, I think it's thinking about how do I get them to the table. Pediatricians generally are very kind people who care very deeply that children get good care. So it's finding out who is there in your community that you can engage to make sure that your protocols have been reviewed by somebody with pediatric expertise, or thinking about how do you make somebody an available resource in those cases. So the last thing is sort of related. I guess these are all related. They're in one section, which is that you have a destination policy that integrates pediatric specific resources. So tell me a little bit more about that.
In my mind, it really comes down to community versus pediatric specialty hospital. So trauma is going to be pretty straightforward as far as age cuts when you go to, I should say, mechanism or injuries that push trauma center, and then age cuts when you're going to go to peds versus adult. That's pretty clear. But I think it's a little more decision making as far as, hey, I've got this kid with bronchiolitis. When can I go to a community hospital versus when should I go to a pediatric specialty if I have one within range? So I think it's important to drive resource centers where we should get the patient to under specific circumstances. I know locally a lot of the hospitals don't want you bringing them kids anymore. So I know in the city, pretty much, our children's hospitals are the one that takes a lot of kids at this point. But I think if you're in more outlying areas and all you have is that community hospital versus a long drive to get to the specialty resource center, how do you make that decision? When should you go there? When do you consider flight versus a long ground transport? So I think it is important to have those policies structured so you have some place to get started.
I think it's also important to know what those resources are within your community, and how far is your nearest tertiary pediatric care center, what counts as a trauma-based system center, what counts as a burn center, to know those ahead of time, right? And it sounds like common sense, it's something you should have in place, but we actually have a nice table of hospitals throughout our region and dots to say, the specific types of care that they provide, and delineate the resources. So I think it's important to know ahead of time the healthcare systems within your community, and what they offer from a pediatric standpoint. You know, some of that information, you know, if you're in an institution like we are in Pittsburgh, where it's, you know, one of the main healthcare systems in the state, that might be easier to find the resources. If not, you might need to go hospital to hospital to figure out, for instance, you have a kid with a long bone fracture. Does this hospital have access to any pediatric orthopedic surgeon, or are they going to have to do a secondary transport to a tertiary care center, pediatric tertiary care center, to get to a pediatric orthopedic surgeon? Or does the orthopedic surgeon at that community hospital feel comfortable resetting the bone of a child, or are there orthotechs available that can do that? You would want to know that information ahead of time and then kind of make your decision from there.
Yeah. And I think that's exactly, it's like going ahead of time and thinking, do we know what resources we have? Like one of the things in our region is we have for women in labor, right, at different weeks of gestation, right, like NICU versus special care nursery and all those. So we didn't have a lot of guidance about which hospital takes which patients at which gestation and had like the appropriate neonatal resources. And so like we had to go to each hospital and have them say like, our nursery takes this gestational age and up, so that we could provide guidance about where people could take the patient so that the impending patient was actually ending up at the right level of pediatric resources. So I think the big thing is, no matter where you are, whether or not you have a clear specialty care hospital right in your jurisdiction, or you're someplace where that's really far away, knowing where kids with different chief complaints, issues, potential complications should go, and giving guidance to EMS clinicians about where they should go and when, I think is the ask. So that is talking about the other piece of policies, procedures, and protocols. And we're only got a little bit left.